Through this video presentation, we emphasize on key zones of nerve injuries and essential steps for autonomic nerve preservation during total mesorectal excision. Here is an illustration of nerves we encounter during abdomen and pelvic phase of TME. Sympathetic supply of rectum is via the right and the left sympathetic chain, which in turn receives postganglionic fibers from the first and the second lumbar nerve roots. These fibers form the inferior mesenteric plexus at the root of the IMA, which continues down as the superior hypogastric plexus anterior to the bifurcation of the aorta. The right and the left hypogastric nerves leave the superior hypogastric plexus, arch around the rectum, and join the parasympathetic pelvic splanchnic nerves to form the inferior hypogastric plexus, which is located on the anterolateral aspect of rectum. The first key zone is at the root of the IMA, where the inferior mesenteric plexus can get injured, which can be mitigated by wrapping to intra-sheath nerve separation technique. Next, at the pelvic brim near the sacral promontory, where the hypogastric nerves may be injured. Third, during the development of the horseshoe shape posterior and posterolateral TME plane, where the parasympathetic pelvic splanchnic nerves may be damaged at the side wall. And finally, during anterolateral dissection of the rectum, the inferior hypogastric plexus is at risk. In this video, we demonstrate the surgical techniques to minimize nerve injury while maintaining the completeness of TME. Our patient is a 62-year-old lady with poorly differentiated adenocarcinoma of mid to lower third rectum. She was treated with neoadjuvant chemoradiation and response assessment MRI showed residual disease. She is planned for robotic ultralow anterior resection. Patient is placed in 30-degree low lithotomy and 30-degree left up position. The ports are positioned as illustrated. The 20 key steps have been outlined here. The arm 4 retracts the IMV towards the anterior abdominal wall, following which the ligament of Treves is incised and the dissection continues craniocaudally along the IMV. We follow IMV first submesocolic approach, which facilitates safe dissection along the embryological planes of the colon, as is demonstrated here in the video, where the dissection continues in a medial to lateral fashion, staying between the visceral and the parietal layers. The anatomical guiding points are Toll's fascia and the unbreached mesocolon. The IMV is skeletonized and high ligation is performed at the inferior border of the pancreas to optimize the reach of the colon. We perform a transmesenteric Lesesac entry by meticulously and diligently dissecting along the anterior surface of the pancreas without causing any potential hazards by staying in a distinct facial plane on the pancreas. Body and tail of the pancreas and spleen can be appreciated here. Lesesac entry is completed once the posterior wall of the stomach is visualized. The pelvic phase starts by scoring the right pararectal fold. A good traction and countertraction facilitates identification of the superior rectal artery and the underlying hypogastric nerve. The plane of dissection must be maintained posterior to the artery so as to safeguard the nerve. This later continues as the posterior TME plane. Perception of this plane helps avoid injury to the right hypogastric nerve. As we move posterior to the artery, dissection then continues along medial to lateral submesocolic plane, safeguarding the ureter and the gonadal vessels, which can be appreciated here. We then continue to dissect all the fibrofatty tissue of the root of the IMA, first on the right side, then on the anterior aspect of IMA, till the entire artery is skeletonized. This completes station 16B1 lymph node dissection. We now retract the left colic artery. Our practice is to perform an intrasheath nerve separation technique in which the connective tissue sheath around the IMA is unwrapped. This is done to protect the inferior mesenteric plexus fibers located at the root of the IMA. Here we can appreciate the left colic artery, the IMA which continues as a superior rectal artery, and the location of the left hypogastric nerve which must be selectively preserved. Now the IMA is divided between clips, thus safeguarding the left superior hypogastric nerve as it courses in close proximity to the IMA. Laterally, line of Toll's is incised and the lateral and the medial mobilized space is communicated, which completely frees the sigmoid and the descending colon from its attachments. A complete splenic flexure mobilization may be performed by releasing all the ligamentous attachments. in order to achieve adequate length of vascularized colon to offer a safe, tension-free anastomosis. After completing the abdominal part, we shift to the pelvic phase. The arm 4 retracts the mobilized sigmoid colon, and the arm 1 provides microtraction to facilitate sharp dissection along the posterior TME plane. We can appreciate the right and the left hypogastric nerves here, and the dissection continues caudally in the presacral TME plane up to the pelvic floor, which is opened in a horseshoe manner. Care should be taken not to breach the presacral fascia and inadvertent injury to the sacral venous plexus. The dissection is continued up to the pelvic floor as we continue working on a broad front by incising the rectouterine fold in order to connect the posterior and the lateral planes of dissection. Precise and meticulous dissection is done between the visceral and the parietal facial planes, that is, just outside the mesorectal fascia and at the same time preserving the presacral fascia. The intact presacral fascia protects the pelvic splanchnic nerves that tent along the side wall during this phase of dissection. Dissection at the level of the levator can be appreciated here. Right anterolateral dissection is performed, taking care not to injure the hypogastric plexus. And right posterior lateral dissection is performed while preserving the right pelvic plexus. In similar lines, left anterolateral and posterior lateral dissection is completed. The anterior dissection is started by scoring the anterior peritoneal reflection. Dissection continues along the rectovaginal septum, posterior to the denonvillous fascia. Dissection along the rectovaginal septum continues deep into the pelvis. It is imperative to dissect the posterior wall of the vagina, free of the rectal wall, in order to avoid rectovaginal fistulas associated with stapled anastomosis. After complete circumferential mobilization of the rectum, the focus shifts towards the dissection along the deep pelvis. The hiatal ligament is divided and dissection continues along the pelvic floor up to a point where the medial fibers of pubococcygeus is encountered. One needs to be precise, meticulous, and diligent in order to avoid any inadvertent rectal injury while dissecting close to the medial fibers of pubococcygeus. After ensuring adequate distal margin by digital rectal examination, the rectum is divided with endo-GI stapler. End-to-side double stapled colorectal anastomosis is performed after ascertaining proximal colon vascularity. Air leak test is performed to ensure good anastomotic integrity. A defunctioning ileostomy is performed and a drain is placed in the pelvis. Final histopathology was a poorly differentiated adenocarcinoma, YPT2N0, with adequate distal and circumferential dissection margins and complete plane of TME. Postoperative course was uneventful. Patient was ambulated on post-op day 1, started on clear liquids on the second day, and escalated to liquid diet on the third day with successful decatheterization. Abdominal drain was removed on post-op day 5 and discharged on the sixth day. Early stoma reversal was performed at the end of 3 weeks.